Dr. Gupta, Dr. Chok.
Hi, everyone. Welcome, fellows. So my name is Attasit, Chokechanachaisakul, Dr. Chok, and we have Dr. Gupta, Dr. Katariya, and Dr. Orloff with us with the portal hypertension team. Since we have limited time, so we can go ahead and start with the case. The case is a 29-year-old male with history of cardiac cirrhosis. He was found to have a 2-centimeter cholangiocarcinoma of the left lateral lobe. No metastasis on workup. He was found to have mild splenomegaly, no ascites. CA19-9 was 52. Platelet count was 102. INR was 1.7. Bilirubin was 1. Albumin was 3.4. As you can see on the CT scan, you see at the tip of the left lateral lobe. Next slide. The patient underwent a lab partial hepatectomy. Intra-op, we found that the liver was fibrotic with minimal nodularity. We did partial hepatectomy with wedge resection of the left lateral lobe. Parenchyma was divided with combination of ligature and endoscopic stapler. During the transections, we encountered high pressure portal venous bleeding, and it was controlled. The case is completed without further complications. Estimated blood loss was 75 ml. Next slide. Post-op course on post-op day 1 was unremarkable. AST, ALT were decreasing and bilirubin was normal. Post-op day 2, AST, ALT were increasing to 1,000 and 1,200 and bilirubin went up to 3. Patient is tachycardic, but hemodynamically stable. On post-op day 3, we checked ultrasound and we found that the patient had portal vein thrombosis involving segment 2 and 3. IV heparin was started. Post-op day 6, the patient developed ascites, Asaka, jaundice, but no encephalopathy, and remains afebrile and hemodynamically stable and on IV heparin. Next slide. We're gonna do a breakout room. Is Jill gonna explain this?
Yes, I am. So on the next, hi fellows, on the next screen, you're gonna see breakout room assignments. For right now, just make note of what room number you're in, but don't go yet. We're gonna go ahead and tell you which rooms are assigned to discuss which topics, and then we'll show this slide again. And at that time, we'll have you go into breakout rooms. For those of you who know how to use breakout rooms, you should see that option in your Zoom bar. Go ahead and put yourself in the breakout room you're assigned to when we tell you. If you don't know or can't see the option, just hang tight and Margie and I will get you to where you need to go.
All right. For room 1 and room 2, whoever has got assigned to that room, we call it topic A for that breakout room. The questions regarding to preoperative management, you have to think back a little bit when you first saw this patient and think about the questions are, what kind of preoperative evaluations would you recommend? How will you use each of the evaluation or informations in your management, and why this information is important? What are different methods to evaluate portal pressure? How do you interpret portal pressure and how do you use it in your management? Is portal hypertension is a contraindication for hepatic resection? Next slide.
Hey guys, this is Amar Gupta. I'm over at Baylor in Dallas. I'll talk to you guys about the next 2 topics. So for rooms 3 and 4, you guys are going to do topic B, which is peri and intraoperative management. So this is kind of the operating room question. So what measurements should have or could have been prepared in advance? Sorry, what measures could have been prepared in advance for this patient, knowing that he has significant liver disease? What intraoperative maneuvers, if any, can be performed to help control intraoperative bleeding, especially what was described in this case? And how would you adjust your surgical technique or equipment in this case? What would you use to divide parenchyma? Are there any other tools that you would have in your armamentarium for a patient like this? So that's for rooms 3 and 4. Next slide, please. And then topic C, this is for rooms 5, 6, and 7. This has got to do with post-operative management. So, the patient's had the liver resection and has done relatively well on day 1. What's your differential diagnosis of the lab values that Dr. Choke presented to you? So significantly increased AST, ALT, and total bilirubin on post-op day 2. How would you evaluate your differential diagnoses to kind of come up with something meaningful? What are the immediate and long-term management strategies for post-operative portal vein thrombosis, and how would you manage this patient's ascites? If we get to it, what are the models that are available to predict post-operative liver failure? And the last one is, what are the expected complications of post-op liver failure? What's the natural history of these patients that go into liver failure after resection? And what prophylactic measures do we have to try to mitigate some of these complications? So that's for rooms 5, 6, and 7.
So
At the end, all in.
Sorry.
Okay, welcome back, everyone. So I hope you guys had a great discussion. We're going to start with topic A with the preoperative evaluation with someone from group 1 and 2. Can you guys tell us a little bit of what you guys talked about in the breakout room? Go ahead.
Ayala has already set up and scheduled.
And Jill, if you could bring, or Ellen, can you bring the slide for questions for topic A?
yeah, this is,
Go back now.
I'm gonna have to go back. Hold on.
All right. Do you have any fellows who want to present or just talked about from room 1 and 2?
I can give at least one of the answers from our room, Alex Tamar from Cleveland. So we talked about having the patient evaluated by hepatology preoperatively. So we would have had them seen the hepatology team and made sure that they were optimized as possible. And this is a 28-year-old, and after getting this resected, he potentially is probably gonna be a candidate for a simultaneous heart and liver or something else like that down the line. So probably like getting linked in with that preoperatively would be reasonable. And Ali, if you want to talk about, or somewhere Alex want to talk about what we thought about checking portal pressures beforehand, somebody.
I can talk. I mean, we talked about everything that Alex just said, and just how we can use a properly phased preoperative CT scan to look for the secondary, sequelae of portal hypertension that we all know. We knew this patient didn't have ascites. There was some probably splenic sequestration with the platelets. So, we would look for splenomegaly, recanalization of the umbilical vein, all those secondary signs. Probably defer to GI hepatology to see if an upper endoscopy was needed to look for things like esophageal varices. And sort of used each of those different evaluations to guide whether we thought something more aggressive or invasive, like like the different measurements using, so we can look at, you can use those secondary signs to sort of get at whether a patient has portal hypertension, or you could do the direct transjugular management using the typical interpretation cutoff of greater than 10 millimeters of mercury for the hepatic venous pressure gradient. And we discussed that patients who are, especially patients who are below that cutoff, but even some patients who are above, based on the reading that we had before today's session, those people would still, certainly for a patient like this who wasn't even getting a formal hepatectomy or lobectomy, even this patient got a wedge resection, we would think this patient would still be a candidate for the wedge resection as they received. But if you're doing something that goes beyond a minor hepatectomy, then you may have to, and a patient does have an elevated MELD and you're concerned about, portal hypertension, you might want to do a formal eval and consider the patient for more aggressive preoperative optimization, dietary management, medication management, tips, all those things that you can do to optimize those patients before proceeding with anything more aggressive in terms of liver resection. But in this case, it would probably be okay.
Great. And that you guys are on room 1, correct? Any thoughts from group 2?
No, I think we basically spoke about the same things, Helen from group 2. The first and foremost is the assessment preoperatively, both in imaging wise. We would look for the clinical signs of portal hypertension. We don't routinely use transjugular assessment or PVG, but my other colleagues in the room would use that, and that would help in this scenario too. And generally what's used is the cutoff of 10. Sorry, I'm just in the operating room, just go to a corner. In terms of whether or not it's a contraindication for resection, just as Ali had said, this gentleman had quite a small 2-centimeter lesion, which would be amenable for a wedge resection, so it wouldn't be contraindicated in this case. Certainly if he was, and I would use a Charles-Pugh score, if he had a very high Charles-Pugh score with quite a bit of clinical sequelae of portal hypertension, we would re-evaluate that prior. We spoke about other things such as ICG clearance test and the Lyme access, which I don't routinely use in my institution at all. I'm not sure where else anyone uses that to assess for portal hypertension.
All right. So it seems like you guys are both on the same page. From my standpoint, anybody that I'm operating on with a question of cirrhosis, I think, I would follow a lot of the things you guys mentioned. I think hepatology input's always important. I typically get portal pressure measurements on anybody I'm worried about cirrhosis and get a liver biopsy at that time. Dr. Orloff, I don't know if you had other thoughts.
Yeah, no, I have a lot of thoughts. Am I allowed to speak?
Oh, yeah.
You are. Please, Dr. Orloff, go right ahead.
Okay, well, thank you for presenting this interesting case, and it's quite a difficult one, but I think there's a couple concepts that haven't been covered. One is that every case that has cirrhosis in our program that undergoes liver resection gets portal pressures, and we use that, 10 millimeters, portal systemic gradient, less than 10 millimeters of mercury, that guides us. And then we look at the platelet count is probably the second most important. And then I think there's a misconception about using laparoscopy versus open surgery, thinking that laparoscopy is going to have better outcomes. And these laparoscopy cases in liver resections with cirrhotics usually take twice as long. And we all need to be cognizant that anesthesia exposure to a patient with liver disease, you put a patient with cirrhosis to sleep, wake them up 45 minutes later, their bilirubin's up, their enzymes are up, their INR's up. So my thought is you can control bleeding, you can do a little small midline incision, especially in this case, and you'll be like twice as quick as doing laparoscopy under anesthesia. So that's a point I really want to hit home, because just because, you think, oh, laparoscopy is going to make it less invasive and better outcomes. No, it's the anesthesia and the blood loss that happens because you can't control it with your, overt, bovie, argon, whatever. So I think those are things that I want to hit home to the fellows. The other thing I want to hit home is that every case needs a risk-benefit adjustment. And in a young person, if this person were 70, I would have never thought about resecting, but, and they're going to have some maybe complications, but, they're going to die of their cancer. So you got to look at that risk-benefit adjustment. And I think maybe I should just be quiet now and be ready to answer other questions.
Well, how about if we go on to the next group of questions? Does that sound reasonable?
Yes.
Okay.
All right, so this is topic B. This is for rooms 3 and 4. Just talking about kind of intraoperative management in terms of immediate pre-op preparedness, intraoperative maneuvers, and surgical techniques. So Does someone from group 3 or 4 want to volunteer? Otherwise, I can volunteer one of you guys for you.
I can start. So we discussed in our room. So for the first question, what measures should have been prepared in advance for this patient? So we discussed about preoperatively putting a central line and then just monitoring the CVP, keeping the CVP low, case-wise. Then also we discussed about the positioning of the patient in the reverse Trendelenburg position during the case to kind of decrease the hepatic congestion. We now intraoperatively, we discussed about like just being prepared for a Pringle maneuver to decrease the amount of blood loss that this patient had. And then it was also brought up an octreotide drip during the surgery or preoperatively to kind of like decrease the portal venous pressure to some extent.
Okay, what group are you from?
Group 3.
Okay, anyone from group 4 have any other ideas? Anything about surgical technique? Dr. Orloff made some fantastic points about, open versus laparoscopy. Anything in terms of what you want to use for parenchymal dissection? If you know that you're getting in with a cirrhotic, anything else you want to talk to anesthesia about before the operation?
Hi, Kimberly, where are you going to go?
Oh, you did.
Oh, hi. For, I guess, the preoperative, obviously, discussion with anesthesia, we talked about all the things that group 3 discussed. Also, knowing the patient is cirrhotic, you want to always have an active type and cross, have blood, platelets, and FFP available. And then the restrictive fluid management, maintaining a low CVP. For the dissection, operative techniques, having whatever that your energy device, your preference is. At my institution, we use the harmonic a fair amount, as well as the CUSA. I think anytime you're operating on a laparoscopically, you should have open setup available and ready in the event that there's bleeding that can't be controlled laparoscopically. And then hemostatic agents. And Dr. Orloff actually brought up a good point about actually considering doing it open because it was a peripheral lesion in the left lateral segment. So it actually would probably most likely be quicker done open.
Yeah, thanks. Chad, I mean, am I allowed to talk now or is there somebody else that's going to talk?
Go ahead.
Right ahead, Dr.
Please
Orloff.
do.
Okay, so, yeah, I mean, I think we're all, enamored with laparoscopic surgery, but the fact is that for a cirrhotic, the time under anesthesia is one of the most important aspects of post-op liver dysfunction or function. So if you can get in there open with a small midline, get in there, resect it, it'll probably be a half hour. Laparoscopy, probably just setting it up, insufflating, it'll be an hour and a half. So anesthesia is really important. Number 2 is if you get bleeding and you're doing a laparoscopic case, controlling the bleeding is much tougher laparoscopically than open. So that's another point. The other point I would say is, I think Chad already mentioned this, low CVP, have an anesthesiologist that does liver cases. So you're not getting someone that doesn't understand liver disease, cirrhosis, and doing these cases. And then I think in terms of the surgical technique, do whatever's quickest. For me, it's argon beam, at 100, 90 to 100 to score the liver, then the harmonic, and then the Carmel and stapler. And that lesion's out in maybe, 10 minutes. And you're done. And I mean, this is just my personal opinion. This is not the opinion of the group here, all my colleagues, or the literature, but I guess I've been around the block a bit and I just feel like, this is how I feel that I get the best outcome. I haven't studied this in a randomized prospective trial because that'll never happen, but I'm just trying to impart some of my thoughts. And you can take them or leave them, but Well,
thank you so much, Dr. Orloff. I mean, there's a reason why we invited the invited discussants as we did because of the collective experience of all of you.
Yeah, I want to echo Dr. Orloff's comments. I agree with him 100%. I would do the same. The only thing I like the Aquamandis sometimes for thicker or tougher liver parenchyma. So sometimes I'll use that or the tissue link. I feel like that's sometimes more hemostatic. But outside of that, I think it's really important to get in, get out, get it done quickly. And really have good communication with your anesthesiologist. Anytime I'm doing any sort of liver resection on a cirrhotic, I make sure my transplant anesthesia team's involved in some way. The only other thing that I use intraoperatively for maybe bigger case, I use tags a lot in terms of management and understanding of their coagulation cascade, because they can be deceiving. I've seen INRs of 6 and people being hypercoagulable. So I do use that, not particularly in this case, but in general, I think that's an important tool to use during bigger liver resections and or transplant.
Great. Should we go to the last set of questions?
Sure. So this is topic C. I'll go through this very quickly to give the fellows and the discussants more time. So this is for room 567. Again, if someone can volunteer, otherwise I can volunteer you. So what are your thoughts when you see these increasing lab values and how do you evaluate them? What are the management strategies for postoperative PVT? What models can you use to predict post-op failure? And what's kind of the sequelae? What happens to these post-op liver failure patients in terms of complications, and what can we do to try to avoid them? So if someone would like to volunteer their thoughts.
I can jump in for some of them. Hi, John. So differential diagnosis of an increase in AST, ALT, and T-billy on post-op day 2. This is obviously something that is very concerning. Your heart sort of sinks when you see this on the post-op labs. And so I think one thing that we talked about was, portal vein thrombosis has got to be very high up on your differential. Other things, if you potentially weren't completely sure of the anatomy, and we talked kind of at length on doing this laparoscopically, and if perhaps you stapled across something that you weren't familiar with, or unintentionally damaged some vascular structures, that could potentially be something. And then we would evaluate with this almost reflexively with duplex. There's other imaging studies, of course, that you could get as well, but a liver transplant ultrasound or a duplex that evaluates the vasculature would give you a good view of that. In terms of the immediate and long-term management of the post-op thrombosis, I think anticoagulation was obviously something that you're going to reflexively do. We talked about if there were other more invasive options, and no one in our group had at least had good outcomes with being super aggressive about trying to manage this with with any sort of procedure. I think one of the folks in our group had a particularly bad outcome trying to be super aggressive in managing this with a procedure. So I think anticoagulation would be the mainstay of treatment, at least in our group. And then managing the ascites, we talked about, there's options for paracentesis. We talked about how in the case of a patient who had portal vein thrombosis in the acute setting, that may be more profound in terms of the ascites than you might see in someone who had a more chronic and insidious onset. And so they may have to rely a little bit more heavily on paracentesis. And there's also, of course, medical management for that. The models that we talked about were Charles-Pugh and the MELD score. And then in terms of the expected complications, prophylactic measures, if you're concerned about taking out a significant portion of liver, depending on what your planned resection was, doing preoperative volumetrics. And if you knew your patient had cirrhosis, then you could potentially do portal vein embolization or Y90.
So how about if we move to the discussants? There's also a question in the chat, just going back to, I think, the last group of questions. in regard to what color cartridge stapler do you folks typically use when you use the stapler in the cirrhotic liver?
So
Well,
for me, oh, go ahead.
go ahead.
So for me, it's a lot about feel. I think the feedback is pretty important. And so, you know, I try purples, and if they don't work, you have to upsize and use a black cartridge typically. And really, you're getting to the point of you feel like you're about to break the stapler, but not breaking it. I've broken I don't know how many staplers over my years now, and that's usually what I use for this tougher tissue. But I think scoring it well and kind of making a path for you is important. But in general, for most liver sections, I use purple and then the rare black cartridges.
I've never used black. I use purple, but you know, maybe my cirrhotic patients aren't as stiff as yours. I don't know, but I just, I mean, I think purple's fine, but again, you trade off. If you use black, maybe you don't get the, you know, sealing of small vessels and, you know, biliary, you know, tract because it's a bigger staple, but probably 6 of one, half a dozen of the other.
I personally use Echelon Ethicon products with the vascular with white and gold. I don't think that is. I think it's important to know what the height of the stapler that you use and tissues, but it's more important also that you need to use the products well. You can, you know, like you need to slow down and then pause a little bit, 15 minutes, like they recommend every. You're not gonna fire stapler like all the way through and back, and that's gonna cause bleeding.
There's just to move things along, there's another question that really relates to our set of questions here. And really, you know, Dr. Orloff, your approach to this patient with a portal vein thrombosis that's localized just to segments 2, 3, how would you manage this patient? What are your recommendations?
Yeah, we put them on, you know, the anticoagulation du jour, whatever your hospital, you know, pharmacist likes, whether it's you know, a DACA or whether it's or, you know, low molecular weight. But the bottom line is that if that little portion of the liver thrombosis, it's not a major issue, realistically, because, you know, you didn't do a big resection. That thrombus is not gonna, it's not like it's a main portal vein that's gonna potentially disseminate to the entire liver. So I think it's a trade-off. You gotta look at, is a patient a fall risk? Are they a stroke risk? I mean, you gotta look at the whole patient because anticoagulation is not with its other complications. At the same time, you know, are you gonna salvage this little segment? Maybe, but it's a small portion. So I think you have to individualize all of those measures in terms of anticoagulation. So maybe I'm not answering the question completely, but I'm trying to navigate in a way that kind of encompasses a whole spectrum of patients.
Yeah, and I think, you know, you can follow it with either serial ultrasounds or cross-sectional imaging. And if you see the clot growing, you know, and it's moving towards the main left or the main portal vein, then you have another issue. And so that's what you want to prevent. And if they're higher risk for anticoagulation, you can watch with serial exams and with ultrasound or, you know, CT with contrast. But if you see propagation, I would anticoagulate this patient.
And I would agree. And this is why I don't think we can come with blanket statements, because we have to individualize every patient, which is what, you know, medicine and surgery is about. You know, we're not necessarily protocol driven. We do have protocols, but I think we have to be very cognizant of individualizing each patient. And that's what, you know, the future of our fellows is, because we're going to have all these molecular testings and all the things that we can do to maybe have more personalized medical approaches. So, you know, that's just a sort of a thought from the clouds.
Great. Should we move on to some of those discussion slides and move into the next case, team?
Sure, absolutely, unless Dr. Orloff or Dr. Katariya have any more points about post-op liver failure.
Anybody consider transplanting this patient up front?
No.
The guys south of me in Houston would,
Just
but
asking.
we're not doing any.
Okay, yeah, there's a recent review that just came out of hepatology that was talking about that a little bit, but you know, it's becoming more discussed, but you know, I don't think our group here would have done that off the bat, but more and more people are talking about it, so just an interesting topic.
Well, I mean, I would just add a point where, you know, our median melted transplant is like, 28. So, I don't know that we can get these people transplanted. And that's why we have to be very prescriptive about what we do up front. Another comment I want to make before I let you do the teaching points is that just for the fellows, every single patient is an individual, and you got to approach it that way because they're not pieces of furniture that you can just, shift around the room. So that's one point. The other point is that you're in great training programs. My advice to you would be to any case you have a question about, call your mentors, call the people who trained you, call people like, all the people on this call that are, attendings. I mean, we are here to help you. So don't ever feel like you're alone because there are a lot of nuances that you may not see in your fellowship that we have seen through our umpteen, well, I'm further than umpteen years, but, and we're happy to help. So I guess that would be my sort of closing remarks on this case and some of the discussions that I really feel like we're here to be a group that helps people, trains people, gets you where you need to be, and most importantly, takes care of your patients in the best way that you can. So just know that we're here for you.
This has been a very popular topic. We sent out a survey to all of you, and we looked at it, and this was one of the popular topics, and we can see why. There actually are some other questions in the chat. So Doctors Orloff and Katariya, if you would please take a look at those questions and see if you can answer those questions for the fellows, because I think in the interest of time, we really do need to move on to our second case.
But won't those questions go away when you start your second case? I don't know how to.
No, they're not good. No, they're there. They'll
Okay.
stay. Yeah. And fellows, you'll receive the slides at the end. So let's move on to the next case, and I'm going to turn it over to Dr. Ching-Wei Tzeng.
Hey everyone, thanks so much, Dr. Hagopian. So I'm Ching-Wei Tzeng. Sabino Zani is joining in a second, I think, getting out to OR. And then we have our guest discussants, Nick Zyromski and Katie Morgan, online. And so we're going to set up a STEM that'll be very similar to what we did the last session. Go ahead, please. So this is just one example case, and we'll build off this STEM. So this is a patient with a history of chronic pancreatitis for several years now, has been sober now, has head-dominant disease. We don't have all the cuts, obviously, but just to let you know, and has a large pancreatic duct, and separately you can see has a stent in place because of biliary obstruction. So that plays a role in kind of your decision-making. For right now, the portal vein, S and V are open. The splenic vein is occluded from these chronic pancreatitis issues. And like I say, he's been stented now for 3 years, but doing fine with that. Next slide, please. Next images are basically showing the same thing again, just showing the whole stent, and I think that plays a role in your decision, and then the ERCP showing the issue at hand. So I think we can go to the questions. I think breaking it up into 3 different major groups. And if you want to take a quick look, I think it might be different than your last round.
Yeah, your groups are different. So everyone just find your name and take note what your group is going to be. We will flash it up again, but just so you can take a note of what the questions are that your group will be answering.
Okay. So in the first set of rooms, again, try to pick a group leader. It doesn't have to be the same person, in fact, to come out and speak for your group. For this pancreatic head pancreatitis with a large duct, what pre-op evaluations would you recommend? How would you exclude cancer? Because obviously that's something to think about. And how long would you wait? You know, obviously in the STEM, you've already waited, 3, 4, 5 years. It's not like you've gone to the operating room. How long can you wait leaving a stent in place? And what operation would you choose for this patient? All right, next slide. For rooms 3 and 4, let's change this up. This is a STEM break off the original question. This patient instead now has whole gland disease with a large duct. So whole gland, not just head disease. What pre-op evaluations would you recommend for this patient? How long would you put off surgery? Do you need to do surgery? And if you did do surgery, what operation would you choose? Okay, so this is for topic B, group, rooms 3 and 4. Slide. And then finally, for topic C, whole gland disease, small duct. Last one was large duct. Small duct for this one. Again, what pre-op evaluations would you recommend? Any additional medical testing? How would you decide between medical management in these type of patients versus surgery? Again, kind of putting, how long would you put off surgery and when would you decide? And if you did have to do surgery, what operation would you do? I think y'all can go to your rooms. We give you all, 15 minutes to stay on time?
Yeah, the 15, 20 minutes. We'll give you a warning, but there are your room numbers. You want to pick your room, and like we did last time, we'll post your questions in the chat in your room once everyone is there.
Zani?
All right, thanks everyone. So moving on to rooms 3 and 4. Rooms 3, when you're dealing with a whole gland or large duct process in a similar type patient. So I know we spoke about it before with groups 1 and 2, but what are your thoughts on pre-op evaluations and how you would recommend this?
And Dr. Zani, I was in room 3. This is Matthew from Duke, and room 3, I was the only one there. So it got moved into 4 with Kim, Phil, and Tyler. So a lot of it is along the same lines of the previous question, which is we're going to prehab the patient with improving any modifiable risk factors of their nutritional status, correcting for their hypoalbuminemia, etc. Ensure they're maximized and optimized on their creon, that their diabetes is managed to the best extent it can be. And then ultimately it starts to become going into the second question of how long will you wait, a question of how well we can manage their symptoms and and the conditions. And it's a very difficult judgment call on a case-by-case basis as far as whether any denervation procedures, pain symptoms, etc., can be controlled, or whether we're just at a point where they can't. And then in the background of all that is whether is monitoring with cross-sectional imaging and tumor markers and trying to perform surveillance for underlying malignancy if it should develop during this whole process. But ultimately waiting as long as we possibly can and avoiding an operation at all costs. So that's kind of how we approached it.
Thanks, Matthew. Appreciate that. So let's give it to Dr. Zyromski and Dr. Morgan. So, we were talking while they were in their rooms, timing is a big part of this disease process, and understanding indications of actually when is the right time to strike in these patients is really important. And kind of pearls of wisdom or thoughts when we're dealing with cases like this.
Yeah, so nice discussion, guys. And I think there are a couple things that I would comment on, and the last one is going to be timing.
Number one is we deliberately didn't give you many symptoms here. So one really important question is, why are you operating? A lot of times it's for pain. And smoking cessation is important, and that'll decrease pain in a lot of the patients. It's critically important before you operate on these patients. But are you operating for pain? Are you operating for a bile duct stricture? It's really, really hard to durably treat a bile duct stricture in a hard, firm chronic pancreatitis head endoscopically. They fail again and again and again, and most of the time they wind up coming around to a surgical bypass. Or are you operating for concern for cancer? And I'll just tell you, it's nearly impossible to prove a cancer in these patients. There's calcium in the gland, there's fibrosis in the gland. You're not going to get something from EUS. The CA19-9 in the setting of a pancreas duct obstruction and chronic inflammation is often elevated, even when there's no cancer there. And so that can be a very red herring. So one main question is, why are you operating? And that really dictates timing. In terms of timing, I would absolutely not wait as long as you possibly can for a couple of reasons. Number one is there are good prospective data that suggest operating earlier before the patients get down the pathway of narcotic use and dependence leads to better outcomes. Number two, you can oftentimes preserve pancreas function or even improve digestive function, and some data would suggest improved endocrine function when you decompress the gland. So if you have a good quality patient who has made commitment to their own health by stopping smoking, by eating right, getting nutrition, remaining abstinent from alcohol, if this is alcoholic pancreatitis, then I think that you don't need to wait forever to operate on these people. What you do need to do is match the proper operation, and I think we're going to get into that a little bit more with the third room. And the final point here is we have to be very, very liberal with genetic analysis. Even we've given you 2 large duct cases and 1 small duct case. And so you think about genetic analysis with resection and considering TPIAT, typically for small duct, but you can get burned if somebody's got, and Katie will talk far more eloquently than I about the genetic profile, but you can certainly get burned trying to do a drainage procedure on somebody with underlying genetic changes, SPINK1 particularly, who will have recurrent pancreatitis even with a perfect Fry, Bager, lateral pancreatic jejunostomy.
Very good.
Yeah, I would echo about earlier is better for sure. I think, I think we've all have the aggressive endoscopist at your hospital that, is often your greatest ally, but in some ways will work against you when they send you only this sort of end stage patients who have been, are on their 10th stent and then come to you and are, at that point, nutritionally deficient, have their portal vein has been, they've got portal vein collaterals now because it's been thrombosed, and they've, really reached a state where it's difficult in terms of their psychology and pain management. So I would agree that timing, you don't want to rush in and operate right away. It's not an emergency, and you want to optimize them. But I think, there's great data to show that early intervention in obstructive pancreatopathy is much better than multiple stents over time in terms of durability. And then on the genetic, I'm glad that you brought that up, Nick, because I'm obviously big on the genetics. That the actual anatomic, structural, phenotype of PRSS1 disease is not small duct pancreatitis. Those patients a lot of times have what looks for all the world like an alcoholic pancreatitis pattern. So they'll have a dilated duct, they'll have a very fibrotic pancreas, and so don't just accept that a patient who has fibrotic disease with a dilated pancreatic duct is necessarily your classic alcoholic pancreatitis. And so I think it's worthwhile in all patients checking genetics.
Very good. Matthew, clarify for me again. You were in room 3. Were you speaking on behalf of 3 and 4 or just for 3?
3 and 4, Dr. Zani. We
3
had
and 4.
other members who had in 4.
Okay, so obviously for rooms 3 and 4, clearly from a large duct standpoint too, what operation are you guys thinking? Any different from what we spoke about from our topic A or similar type practices?
So I can chime in to relieve Matt since he's carrying double duty. The things that we talked about in room 4, this is assuming large duct, whole gland disease, but I think the tenets still kind of prevail here that you do everything you can to not operate on them if they're not like overtly symptomatic or if they're not having a lot of problems. We did talk about the operations too, that, for those of us in this group, we have not come from institutions that do some of the more advanced benign surgeries. In residency, I came from a place that there were 3 pancreatic operations. It was Whipple, distal, or total, and we never did any of the other drainage procedures like a Pusteau or a Beggar or whatever. The things that we all memorized for the boards, but we never saw them in practice. And so for these sorts of things, if this patient is not overtly symptomatic, I would sit on them. And if they're becoming more and more symptomatic, if you're at a place that can do islet cell, or if they're already a brittle diabetic, then a total with a islet cell transplant seems more reasonable. But without other findings of more complicated pancreatitis, you don't seem to get a lot, at least from what I've seen, you don't seem to get a lot of the benefit, or you don't seem to get a lot of benefit from operating on these patients, kind of at all. I was trying to qualify that in some way, but in general, like it's a low yield surgical arena for chronic pancreatitis, at least from what I've seen.
There was an actual room 3, so we got moved from room 7 into room 3. So I'll chime in from our group, and we discussed all the things that the room 4 people discussed, but also included that our operation of choice would likely be a Pusteau in the large duct whole gland disease patients. We obviously wanted to confirm that there was no concern or evidence of malignancy with preoperative imaging, including pancreatic protocol scan, as well as EUS with biopsy of any concerning lesions in the head of the pancreas. We also, at our institutions, we didn't do a lot of them, just like the last speaker at Portland. We don't do a ton of chronic pancreatitis, MD Anderson as well. It's kind of more heavy malignancies. And however, one of the members in our group is at Providence, Portland with Dr. Hansen, who does some of these and has an opinion about kind of how to manage them. I felt that it was really helpful, the information from Dr. Zyromski a few minutes ago, because I didn't know either that you shouldn't wait. That was our sense as well, that these patients tend to present to the surgeon years into their disease process. And the way that I was taught this in residency as well as in fellowship is that you would typically manage these patients surgically when the intent of managing them was either to improve the amount of narcotic pain medications that they were on, or to get them back to a point where they are a contributing member of society. So they are on so much pain medications that they can't take care of their children or get back to work. And so your intent was to operate on these patients in order to get them back to being a contributing member of society. And so that was my understanding, but a lot of them usually end up, like I said, coming from GI when they're years into this, and you don't see them prior to that unless you have that relationship with your gastroenterology colleagues. I can't think if there's anything else. Dr. Forrester can chime in from his experience with Dr. Hansen.
Yeah, no, I think that's similar to what we've seen here. And then the sense too is if there's also kind of a focus or an itis of disease in the head, that it's nice to be able to remove that. But if it's kind of too challenging in terms of the involvement of the portal vein, that also including a kind of a bypass as well to the bile duct, if that's involved, is reasonable.
Well, Tyler, Kimberly, and Jared, thanks for that. Really, one of the reasons we chose this topic was it's a very complex disease process, and obviously very institutionally biased, depending on who's dealing with this, as we all know. Kind of dealing with that, Dr. Morgan, Dr. Zyromski, additionals, obviously Pusteau here. One thought is thoughts of even drainage. What about pancreatic gastrostomy, or is it typical Pusteau kind of a favorite procedure for something like this?
Yeah, I favor the Fry procedure just because it seems to, there often seems to be some level of fibrotic disease in the head of the pancreas that can help even in whole gland disease. And so, I think that seems to give the best relief for patients. I haven't had great success with relieving biliary obstruction with a Fry procedure though. So, often if I do a Fry, I'll end up having to do a biliary bypass as well. Yeah, so that would be my favorite operation in that for pancreatitis. I think, in terms of, avoiding operating on chronic pancreatitis patients, I think there are different types of pancreatitis patients. I think a lot of institutions are biased from the classic alcoholic pancreatitis patient that goes back to drinking and doesn't do well. But I think we're talking about a different population of patients here who are very salvageable, particularly if you intervene early. And again, it's not someone who's at the end stage of disease. So waiting until they're on a lot of narcotics and are very dysfunctional in their communities, have lost their mechanisms of support, you're going to have a harder time being successful in really helping those patients. But if you can intervene earlier, they do tend to do a lot better.
There's no doubt that patient selection is primary, the single most important thing. And one of the challenges with this disease is that most institutions don't have a single person or a group that accumulates experience with it, and that suddenly gives the disease process a bad name. Katie's partner, David Adams, called it an orphan disease. And I think that's a very, very accurate description. But there is also no question that if you take an interest in this and you work with a dedicated GI team and you select the patients properly, you can salvage people's lives. So nobody should walk out of this conference thinking that this is a low yield operation or disease process for surgeons, because if you're interested in this, we can teach you about it and we can teach you how to get good outcomes. I think the question, Sabino, about drainage is excellent. The paper that we included by Charlie Fry, Charlie died last week at age of 93 after a very full life. And Charlie Fry and Dana Anderson put together about the history of pancreatic surgery is very illuminating and really very interesting to read. Charlie Pusteau was a Chicago surgeon. His operation involved splenectomy and distal pancreatectomy. That was the Duval procedure, caudal pancreaticojejunostomy. People were afraid to operate on the head of the pancreas. Charlie Pusteau did a distal panc and a spleen, and then got into the pancreatic duct from the left and filleted the gland to the head. And then Partington and Gillespie, who were also Chicago guys, realized you didn't have to take the spleen out, and they modified Pusteau's procedure to do what we now call a lateral pancreaticojejunostomy. But I think Katie's point is really important. You must decompress the head, especially in a patient like this case that we gave you with big bulky disease in the head, whether or not the duct is dilated to the tail, whether you do a Bager operation, which divides the neck of the pancreas, which is a little more hazardous, trying to dissect under the neck, or Charlie Fry's operation, which is just coring the head. You should really focus on trying to core the rest of the head. Otherwise, you'll have recurrent pain. If you get into the bile duct in the head of the pancreas, that's no problem. You just have to open it longitudinally in the head and tack it in like you would do a sphincteroplasty or something like that. Or it's also quite nice to do choledochoduodenostomy in that setting for biliary bypass. I've tried to put the bile duct on that roux limb up for lateral PJ and just have really not been happy with the way it lays. So, but I think that yes, decompression of the bile duct and the pancreas is fine. Another take-home point is if you're going to spare the duodenum, you got to make sure that the duodenum is not a problem. So duodenal preserving pancreas head resection doesn't do any good if the guy's got a duodenal stricture, he can't eat or something like that. So.
Very good, thank you. Moving on to topic C, rooms 5, 6, 7. So maybe for room 5 here, a little different disease process here, a little bit more nuanced, if you will, and talking about regionalization here and some of the options here. Not many centers have the capacity to deal with this in full and total of what are some of the options that you can do for this. So what pre-op evaluations would you recommend here? Any genetic testing thoughts? And how do you decide between medical management and surgery? What do we have on for room 5?
Yep. So pre-op evaluations, we discussed, as was alluded before as well, just obtaining basic labs, CBC, CMP, making sure that that biliary stent is working, LFTs are not super high, obtaining some tumor markers, nutrition parameters, HbA1c, and smoking cessation. So all of those parameters we discussed as far as pre-op evaluation is concerned. For genetic testing, we discussed about SPINK mutation, testing about that. Then also the PRSS1 mutation we discussed about, obtaining an IgG4 as well, even though not necessarily genetic testing. So those were the things that we discussed. As far as choosing between medical management and surgery, so trying to optimize the patient medically first, and after failure of medical management in terms of significant narcotic usage for pain, or if the patient is requiring multiple ERCP and recurrent exchanges and all that for obstruction, then going on to surgical management. So that was that. And operation-wise, as Dr. Zyromski pointed out, depending upon what the primary, symptom is, like if it's being done for pain or biliary stricture, or it's a suspected cancer, but the consensus was like doing a total pancreatectomy with islet cell transplantation. And since this patient had a splenic vein thrombosis as well, probably including a spleen as well, performing a splenectomy.
Very good. Room 6, 7, anything to add there? I know we're kind of running close on time.
Just one quick thing from 7. We do mixed meal testing in people that we're considering for islets to see what the total residual islet function is. I don't know if other hospitals do that do islet cell transplantation. And then we would try to have them seen in like a multidisciplinary office where they're seeing a psychologist, sort of at least we do here, it's sort of a multidisciplinary approach when we consider people for islets. And we thought the only 2 operations, after all the genetic testing and done, would be, a total panc plus or minus islets if you're operating for pain, or just a biliary bypass if that was their only issue they were having, and optimize endocrine exocrine function.
Very good. Dr. Morgan, you want to touch base on some of these thoughts?
Yeah, I think as much as Dr. Zyromski was talking about preoperative selection, I think it's huge in these patients, and that you often have people that objectively on paper and particularly anatomically seem ideal for this operation, and that they have failed lesser procedures, they have diffuse small duct disease, whatever it is that makes them seem ideal, but these patients really need to have adequate coping skills and support mechanisms, way more than the other procedures that we do for chronic pancreatitis. It's a big operation, and really you're trading, as much as you're transplanting islets, you're trading kind of one chronic disease for another. And so these patients certainly will have challenging both endocrine and exocrine insufficiency that needs to be addressed long-term. And so they kind of need to be well prepared for that, way more than the traditional drainage and resection procedures. But yeah, I think this is a different group of patients. They look very different than the patients that you're offering the other procedures to. And so, I think it's remarkable how different they are. It's not the usual. And in fact, John Christine showed us at UAB that the alcoholic pancreatitis patients actually don't do well with total pancreatectomy with islet autotransplant. And I think it's probably for some of the reasons that I just mentioned.
Well, I want to thank all the groups. Nick, you want to add any final thoughts here before we go back to Ellen? I think we're just a hair over time.
Very, very quickly, a couple questions in the chat. One is insightful question from Matthew Strand. Does endoscopic response play a decision in operation for pain? We tried to look at that prospectively with a multi-group study 10 years ago and weren't able to show any positive outcomes. So the question is, if somebody's got a stricture and you stent them and the pain gets better, will they do better with surgery? The answer is we don't really know. It makes sense intuitively, but don't get too far down the path of stenting. There are also probably the best prospective data shown in chronic pancreatitis, looking at surgery first versus endoscopy, European data that show long-term that surgery is more durable. And then a second quick question, does the length of the anastomosis in the lateral PJ put you at higher risk for postoperative pancreatic fistula? No, the short answer is no. The gland is usually firm and it's more challenging. I would say open up the lesser sac widely, make sure you expose the tail very well, and make sure that you don't leave a stricture with upstream obstruction, upstream towards the tail. But the length of the anastomosis, I don't think has any influence on fistula. Katie?
Yeah, no, I would agree. I think, as you said, this is kind of the foolproof pancreas. The perfect Pusteau pancreas is usually not going to leak just because it's such a nice organ to sew to. And I would also add that for those that have any robotic skills at all, this is a very easy platform for learning robotic surgery is to do the Pusteau, because it's pretty straightforward robotic skills wise, as long as the duct is big. So you need to have the hard part is just getting into the duct minimally invasively. But once you do that, then it's a nice operation.
Final comment, sorry for running over. Total pancreatectomy and islet transplant. I mean, any chronic pancreatitis patient is absolutely 100% multidisciplinary. And if you're thinking about islet transplants, it's endocrine, psychology, nutrition, pain management, complex GI, experienced pancreatic surgeon. I mean, it is a village to take care of these patients. You cannot take care of them by yourself.
Thanks all. Ellen, I'll hand it off to you.
Yeah. Oh boy, that was really fantastic. Thank you so much to all of our discussants and our moderators who developed the cases. Thank you so much. And thank you to the fellows too. We are a minute over time. I can't believe that we're only a minute over time. We were discussing earlier that we're really interested in hearing what the fellows, what all of you thought of this particular session, any suggestions, what worked well, what didn't work well. So please, when Jill sends you out that evaluation, please fill it out and get it back to us, because we do look at it. And we do this all for you folks. So thank you, Dr. Orloff, for coming, Dr. Morgan, Dr. Zyromski, Dr. Katariya had to step out, and to all of our great moderators. So thank you, everyone. Good night.
Thank you. Bye.
Thank you.